Don't sit down. Of course, it's up and down. I get to exercise. It's good to do that in the hospital. You get to join us on the board. All brand new board members. You get to have the excitement of being coming here every month to endure 3 or 4 hours of wonderful regalia from our wonderful staff. So I'm going to administer the oath of office. And would you raise your right hand, please? And repeat after me, I. Okay. Do solemnly swear that I will support the Constitution of the United States of America. And the laws thereof. And will faithfully and honorably demean myself in the office of Lake Health District. I will faithfully and honorably demean myself in the office of Lake Health District to which I have been elected to the best of my ability, so help me God. Congratulations, you are now officially board members.
And now we have a quorum.
And we have a quorum. We can go ahead and thank you. Okay, next item is public comment, and I see public here. So who would like to step up first? Shall we take Glenn's?
You take Glenn's.
Okay.
I guess we're here because we received the letter in regards to John's mom, my mother-in-law Nora Flynn, who resides over at Lakeview Gardens, that there's going to be a rate increase of about 15% for her care beginning with the month of August. And I guess I just have a real concern about that. In about another 6 weeks, she'll have been a resident here for 3 years. And in that time, we're pushing about $400,000 that we've paid for her care. And fair chunk of money, she's had it, so she's been able to pay it. We'll see how much longer that goes. But my real concern is that, you know, we keep raising the rate, but I'm not seeing a change in care. And the care, at times, is pretty questionable. Example, week and a half ago, maybe 2 weeks at the most, I popped in to see Nora. I usually go down somewhere between 2 to 5 times a week. Never go at the same time because I've never wanted her to get used to me showing up and being disappointed if for some reason I didn't make it. But I was there, it was about 10:30, 10:40 in the morning. She was sitting out in the foyer and didn't have her glasses on. And I'm going, well, hey, Nora, what are you doing? You know, where are your glasses? And she's going, I think somebody took them. And granted, she's struggling a little bit more with her mind power. But so I sought out a CNA. There was nobody around. There was another patient or resident sitting a couple chairs over. I sought out a CNA, kind of just slumped in there, just hanging out. And I'm going, excuse me, but my mother-in-law, Mrs. Flynn, doesn't have her glasses, and she wears them every day. And he's going, yeah, I know. I'm going, well, I did receive a call saying she'd broken them, so where are they? And his response was, you know, I really don't know. And I'm going, well, you know, that's not an acceptable answer. She has trouble seeing with them, but without them, she can't see at all. And I'm going, so you need to find them. He's going, well, they weren't in her room this morning, and I had walked in and checked the room, and I didn't see them, in fairness. And I said, well, then you need to get someone here, your superior, because we need to find her glasses. You know, and if she's lost her glasses, somebody should have called the family so we could have done something about it. Well, with that, he went and got, and this was a traveler who's, I don't know his name, but he went and got Mary Forgo, who was down around. He went and found her. She came. She went in and found the glasses, brought them out. He had them in his hand. He comes up to Nora. And he didn't say, touch her shoulder, say, Mrs. Flynn, I found your glasses, I'm going to put your glasses on you. He just, whoop, put them right on her. And you know, you're dealing with a woman who's 90. Kind of on the struggle bus anyways. And I'm just going, wow. And we're paying how much for what kind of care? just really disappointed. And then right after that, we get the letter saying, oh yeah, it's so great, we're gonna have, but not 3%, because I get that. Expenses go up, you gotta pay for them, 15%. So, anyway, that's my concern, is I think it's too much of a bump, and I think that care has gone down. I know that there's less people in the house, residents, so I know there's less people giving care there. But you still, when you're still charging these kind of monies, you gotta make sure these people are taken care of. And I'm just really questioning where we're at this point, so.
I'd do anything for my mother, and we started out at a reasonable rate, and right now we're gonna be over $10,000 a month. How many people can stand over $10,000 a month? And, we're doing the best we can with what, because we can't move her, relocate her. And it has eaten her up hand over fist. I called DHS in Klamath to find out how the state is handling this, because I don't know how many people are paying down there now. I know Lois, God bless her, she's gone, my mother, my Uncle Jim, and honestly, I don't know how many people aren't on the state program. And I was curious about how the state is paying. Are they paying over $10,000 a month per patient? Or is it just those of us that can afford it? And that's not right. That's profiling. And I'm going to find out. But I called the DHS, I talked to a lady, and I'll tell you what, she was very polite. She did not want to get into it at all. And I'm not going to mention her name. I felt really bad for her. And it wasn't but maybe 3 days later, I was down with my mother. I walked into her room, and she looked like a bag lady. Somebody out on the street. Her clothes were filthy dirty for afternoon breakfast. It was all over her pants. She doesn't wear a skirt. So I got a wash rag. I cleaned her up. There's a CNA out in the hall. I gave her the, would you please come in? And I asked her, I said, what is this? We're paying not over $9,000 a month for my mother, and she's looking like this. No excuse for this. And she goes, well, I'll tell you what it is. There's only one CNA on duty. There's one roving RN, and she can't be everywhere, and she's supposed to help us. And I thought, that's a crock. There's 6 or 7 people in this building. I said, my mother looks horrible. If her peers came in, the Dorothy Howards, the Donna, people, Harlans, came in and saw her, they would think, what in the world's going on? Why don't you take care of your mom type deal? And I will tell you right offhand here, folks, those people, some of the names I just mentioned, are not going to go into this facility down here because they see what's going on, the care. And I'm up to here, but I won't dare move her because Tilly and I and Kirby's in town, and we can stop and visit her. We could take her away and put her somewhere else. I've shopped. There are a series of nursing homes, Charlie probably knows about them. They're down in Sacramento area where my sister is, and they're called Eschaton. There's a lot of them. There's people down there in the same condition as my mother, the same amount of care, $7,500 a month. I got a price quote. So I'm just going to tell you folks, and I'm not, the new members of the board, I'm not here to beat you up. I just want you to be on top of things. I think we're too top heavy in this organization. And I've received that word from people that work down there. There's too much upper management and not enough laborers. And they are afraid to come to the board with their complaints for fear they will be retaliated against. And they need their jobs. So that's kind of why we're here today, Tilly and I. And it's not over. But we can't, nobody can afford what's going on. If the state is down here, they need the same care as my mother. But we should be treated the same as those folks. And that's where I'm going to leave it. Because, I've been upset about it. Because every time I go down to see her, it's a shock. It's a shock. And, every time I've ever been down there, Charlie might show up on Thanksgiving or Christmas. You never see another board member down there. I don't think people knows what's going on. Shireen, hell, she spent a lot of time there. Her mother-in-law was there. And, you know, I'm not gonna put her in the corner, but her husband and I sat right here a few times. And we just will talk to our dogs in the front seat of the pickup. We've received no satisfaction whatsoever. But when you're paying over $10,000 a month, you need some pretty good services. So I'm gonna leave it at that. So I'd appreciate, you know, you're probably gonna talk about it. I wanna hear the findings you come up with, because it's awfully hard to get information either out of here or any other agency. They just, you know, they can dance around. And I run a pretty good sized business myself, and that is the way I run business. So, thank you very much.
Okay, well, thank you, and we'll be looking into it, you can rest assured.
Well, could I just say that these are the same concerns that we had October 5th, 2017, a lot of them. And I'm still working on it. I'm not going to give up, because Marv was down there and we were paying well over $10,000 a month at that time. But there has to be better care. There just needs to be, and it's the care is questionable because there is not enough staff. You just can't have one nurse running back and forth between the buildings and a shared aide and everything like that. People are stranded if they're in the dining area. They're stranded. They have no way of contacting anybody to say, I need to go to the bathroom, I need some water, or anything. And I know I have a sister who's in a long-term care facility in the Detroit area. And I go back there 3 or 4 times a year. And I have brought back several suggestions. But I'm not invited to the meetings anymore because Marv passed away. But there are several things that could help, that would just make it more responsible on the part of the staff, and the residents would have more care. There's just not the care that is needed. My sister every day gets massage care and everything. Yeah, she's a bad diabetic, she's blind and everything, can't see, but it doesn't matter. She gets care. And they have choices in what they do, and they have activities, and they have stimulation every day. But there's really not, it's up to the family to do the stimulation, I think, you know. So the care that you're paying for, I think we can do better. Lake County needs a long-term care. We need that. And I know I promised Marv before he passed away that I would try, and he kept saying to me, you know, Lake County needs this. Please keep working on it, you know, and make it better. Well, that's what I'm here to do, is to always try and make it better. And so sometimes you have to listen to the families and say what works, you know. And people should never have drool on them. They should never be left in dirty clothing. I don't care if you change them 4 times a day, you know. But some of the same problems are still there that were there right after the opening. So anything that can be addressed, and I'm not sure, that I'm finding out that this is not really the board that governs the Lakeview Gardens. And I'm still trying to find answers on that. Is there another board?
There's the,
And if so, what's the name of that board?
it's the Goose Lake.
Goose Lake Board?
Goose Lake Medical
And
Services.
who's on that board, and when does it meet? And what do they do?
I'm not sure when they meet. They have an annual meeting, I know for sure, but the Goose Lake Medical Board is part of our board is on there. I know that Judy was on there, and I'm not sure that she's on anymore.
She's still a member.
Could you explain to me what the Goose Lake Board is?
Well, have they ever met?
Yes.
It's the best kept secret I've ever heard.
Yeah.
I mean, are they the ones that,
No,
are they the ones in charge of the finances, or are they just
No.
an entity?
they're a separate entity that was formed for legal purposes for the Alturas Clinic and Lakeview Gardens. Okay, so they are the legal entity, just like we are the legal entity overseeing the hospital, and we also oversee them. The operations are controlled by our administration, okay? Both organizations are very closely related, but the operations are through our administration here. So it would be Charlie and Mary and the others that would be operating Lakeview Gardens. They're the ones that are in charge of hiring and firing, and also overseeing the training and the operations of the Lakeview Gardens and the Alturas Clinic.
Okay, then what's the purpose of the other board?
It's a legal entity that,
A legal entity.
it's a legal entity, right. When we organized the Alturas Clinic, we needed to have a separate legal entity to take care of that. But the operations are contracted and run through this board and our administration.
So they really don't make decisions.
They have a budget that they look at, but they don't make the true operating decisions for the hospital or the Lakeview Gardens, okay?
So they're not the ones that raise the rates.
No, that's an administrative decision. It's not a board decision. You have to understand, the board is responsible for policies and procedures and for things like this, but we don't get down into the weeds making a day-to-day decision as to how much to charge or who is to charge or any of the operations. That's what our administration is for. We hire Charlie to do that. Charlie hires the people, the administrators and the bureaucrats, if you will, that run all of the different departments, okay? So we've got public health, we've got behavioral health, we've got Lakeview Gardens, we've got the clinic, we've got the ER, we've got the hospital, physical therapy, all of the different things that go on. There's very many moving parts. So we have a difficulty with Lakeview Gardens right now. I can assure you we'll get down to the bottom of this again. Last time we lost somebody, but we'll continue to look at this, and I know you're upset, and we're going to get it done. Yes?
I would say that, you know, a lot of it for me stems just from concern. And John wasn't totally on, but when Nora first came and was in the facility that was part of the old nursing home, at that point we were paying over $12,000. So it dropped. When they moved to the new building, she was still at $12,000, and then it came up at a meeting in October or February or whatever, sometime in the winter months, and it was like, well, yeah, no, she shouldn't be paying that amount because everybody has a private room, because we were told she had to pay that amount to have a private room. So then at that point, her rate dropped to about $8,900, just below $9,000. And right now we're paying about $9,900. Sometimes it'll pop over 10 depending on if it's a longer month or not. And with this new increase, it's a little over $1,400 additional. So where we'll be on a 30-day month, you'll be about $10,700 is about where you'll end up with the payment. And so I guess that's part of my thing, is that, like, you know, we're paying these prices and you're going to pay whatever you can to have your loved one taken care of, but you want to make sure that they have the best care they can have. And I mean, and I understand a lot of the issues that you're up against if we've been there long enough, but I also know that most of the CNAs we have now are traveling. I would say 2/3 of them are travelers, maybe 1/3 are locals. And you know, local people just are better because they have more of a buy-in or something. They know these people, they can talk to them about things that they're familiar with. These other folks, you know, if Nora's stumbling with something, these folks have no idea where Howard Struggs is. I mean, they're not familiar with the history of the community. And so, and what I've been told from the various CNAs that have been there and no longer are there, part of the reason they left is they did not like their treatment. They felt they couldn't get a schedule that was consistent. They would get a couple day shifts and they'd swing to night shifts, and then they think they have a schedule and they'd change it up again. And they're just going, this is crazy. You know, I don't want to work this. I want to have a life too. Not that they didn't want to work full time, but they wanted to know where, so they could plan out their life, which is, as we all know, with employees, paramount these days, that they have a life too, so, which is good. So I just wanted to clarify that.
Okay. Well, we are, we do have the program with KCC to try to develop local talent, if you will, and it's, it's an ongoing difficult program to hire and keep good employees. And a lot of them will move out of the area and get married or what have you. So it is a continuing problem, and I'm sure that the administration is taking a look at it. We'll probably look over their shoulder a little bit more now.
Thanks.
I have a clarification question, Charlie. So, Don, I'm still not, it's the first I heard of the Goose Lake Medical Board. So there's a separate board that meets monthly that runs the nursing?
They only meet on an annual basis.
So about 8 years ago, the history of this is you have to understand how we get paid for services. So you have to look at, as an entity, what are the best ways to get Medicare and Medicaid to pay for healthcare services. And in the hospital side, we get paid by Medicare and Medicaid, which is about 70% of our business, based on what our cost is. Not what we charge, but what our cost is. The long-term care doesn't pay, most of the business is paid for by the Medicaid. That's the state program. So John, your question, how much of our business is the Medicaid portion? In the long-term care component, the state actually charges us $150,000 tax if we have less than 85%, or less than 85% of our patients are Medicaid. And so at the recommendation of our attorneys and our auditors to try and maximize the payments, I know this gets into the weeds, and so I apologize for the explanation, but to maximize the payments for the hospital, and that's where most of the expenses are, we formed a separate company to own the long-term care facility. That's what Goose Lake is about, okay? So all of the employees are what are called leased employees. So they all work for the health district, and they're rented, if you will, to Lakeview Gardens. There are a lot of reasons why we did that. The building is owned by the health district, but in all of those, that helped the payments for the hospital. That's why we separated. It also, we put other businesses in there, so our durable medical equipment company is there. We did have the clinic in Alturas there. That's now part of the hospital. And some changes. These are structural changes that we can talk about at later times. It's just it gets complicated. But the operation of the long-term care facility is managed by the health district. How did we come up with our rates? Probably one of the questions you want to ask. At our, every year we prepare a budget for all the entities of the organization. We present that based on recommendations that we've made to the board on what we think the world is going to do in healthcare. We present that and review that in our budget meeting, just like all the public entities do. The budget committee approved that. That was sent to the board last month at the June board meeting. That was approved. That rate increase was included in our budget that we presented based on what we think we can afford and how we can keep the entire entity afloat. And that's really our business. So that's how the rates are established. That's why there's a separation of the companies.
But that separate Goose Lake board does not give direction to administration or, okay.
The membership of that Goose Lake entity is 2 members from this board And Judy was on that board as well as Ken has been. Then 2 members of the Lake County, Lake LCDC, which is
Lake County Development
Corporation, which is an organization that's interested in the development of the community. And the 5th person is the medical director, who is the chief of staff of this organization. So the medical staff is part of the hospital. Then all the doctors are part of that, and they elect each other to be the chief of staff. So that's the membership.
Who is the correct chief of staff?
I beg your pardon?
Who is the correct chief of staff?
Dr. Steve Hussey.
Okay.
You might touch on the difficulty in having CNAs and their turnover. It was touched on scheduling as a factor. Maybe you might elaborate more on that if you could.
See, the world of CNAs is a challenging situation. There isn't a community that is not struggling with this problem. A large part of it is that it is no longer viewed necessarily as a profession as it had been in the past. A lot of times people would take a job as a CNA and stay in that job for a long time. Now, a lot of schools of nursing require that students to get into nursing school have to have worked as a CNA. So many of the CNAs take this job with the intent of just working for a little while and then applying to get into nursing school. Many of our CNAs have done that, have now become nurses, and have gone through the Clement Community College program. We have a hard time finding people that are in our community want to work in this job. It's a hard job. And they have lots of options. And a lot of the younger people that we encourage to take this job, they start it and then find that it isn't exactly as glamorous as they thought. And it's hard work. We put on trainings for CNAs, and we have been doing that for a long time. And sometimes we get a good class and they are interested in staying, and sometimes, well, we have to keep looking. It's a struggle to deliver that care. Unfortunately for us and throughout all the organizations. So I'm not just saying, I'm not whining, I'm saying this is a constant problem. The cost for a CNA is oftentimes 2 times what it would cost if we could hire them. Because these agencies charge a lot of money. So we have every incentive to try and hire local people. Tilly, you're absolutely right. We'd love to have them. If we could find them, train them, and keep them, we would. But we still have to provide care. And if we can't find somebody, we have to hire agencies. And if we could change that, we would do that in a heartbeat. It's just hard to do. Does that help answer that question?
Okay. Well, we got our work cut out for us there,
We do.
and we'll expect some results here pretty quickly. Okay, moving on, more public comment. I see the Howards here.
We're at number 9.
Are we number 9 or are we public? You're number 9.
Number 9.
Unless you.
Okay. I don't.
Unless you have something else for now.
Nope.
We're going to start.
Take a stick to our
I'm
section.
doing, I got the old.
You're on the draft.
Okay. Well, any other public comment? Okay. Hearing none, we now come to the portion, let's see, Charlie, you have some SDA training?
So-
Small districts.
Right. One of the things that we have, as a public district, we have an opportunity to access what Special Districts Association provides to us as a health district. One of those things is board training and board education. We had a good session a couple of weeks ago. We have an opportunity, I think I provided that information to you, about some trainings that are coming up. There is one in August 21, that I think, Ken, you have indicated you would be available, and John, you said you would be available. Shereen, would you be available, or is there another time that, do we have a schedule for?
August 21st?
Yes,
Is that the one in Redmond?
that's the one in Redmond, or excuse me, Medford.
Medford.
It's in Medford. There- You will not be there. There are some opportunities, and we can get you those dates. But we think it would be really helpful.
That was end of the 13th.
And of course, one of the things that
Yeah,
helps,
I thought we were at the 13th in Redmond, is what I was told. That's why.
Okay, I had the wrong location for Charlie then. I'll verify that. I've coordinated for the two of you, so I'll look and see what we signed up for. But I, for some reason, had it stuck with Medford, but I probably did Redmond then, if that's what we talked about.
Okay.
Is that what-
But I will check on that and let you guys know tomorrow.
there is one on August 13 in Redmond, and on the 21st in Medford.
Then.
One of the advantages we get, we do buy some of our liability insurance through the special districts. And if we participate in several of the items that they think really help districts, that helps reduce our premiums. So we think it's helpful for you, but it's also helps the organization. So if you have those times available, we appreciate that. Okay?
Okay. Next item is approval of the consent agenda, and we've already given you guys a chance for the check signing. And there's nothing else. There's some suggestions and thank you letters in the consent agenda. So I would entertain a motion to approve the consent agenda as presented.
Can I ask,
Sure.
is this the consent agenda? What is the consent agenda?
Consent agenda is normal housekeeping items. For example, on this one, all we really have is the signing of the calendars for the checks. Sometimes there's some other items that will come up, and then we'll cover those when they do come up. But a consent agenda is just housekeeping.
Sometimes it'll be the minutes. For example, we did have the minutes for the June meeting,
Right.
but
Gerald's not.
Gerald's not here, so we didn't think it was fair to ask you to approve minutes that you weren't there at the
Yeah.
meeting.
In other words, we would normally approve the previous minutes with Gerald not here and you guys having not attended that meeting. We'll wait and approve them at the next board meeting when we have a chance.
So what is it we're being asked to approve today then?
Today is just simply the calendar,
I so moved.
okay? Okay. Moving and seconded to approve the consent agenda. All those in favor?
Aye.
Passes unanimously. Okay, now we get to the meat and potatoes here. May 2019 financial report.
Did you want to do the election of officers?
Oh, well, we could do that.
Kind of neat though.
You got me all confused here. There it is. Okay.
Sorry about that.
That's okay. Election of officers. We are gathered together to elect a president, secretary, and treasurer. Gerald is not here. Gerald has expressed an interest in running for treasurer, or secretary, excuse me. We need a nomination for president and treasurer.
Well, I would move that Don consider being president again, since the other folks here
I would-
are just learning what is going on.
Love to have Gerald as president, but he declined that, so I think I've got the most experience, but, you know, maybe you guys will impeach me later, so. But I'll accept the nomination for president.
I'll second that motion.
And for secretary, I nominate Gerald. And for treasurer, John, would you like to be treasurer?
For the audience, explain the duties of each.
Well, the secretary and treasurer, secretary is really dependent upon, you know, that's for providing the recording of the minutes and making sure that our agendas and everything are set, presenting, getting all the information out for us. Like the meeting agenda, any questions you have in regards to rules, regulations, and laws would go through either Jen or Charlie. But the secretary would be responsible for getting that dissemination out. The treasurer is responsible for the financials. Largely, Cheryl would be the one that you would be looking for the detail, but the treasurer is the one that's responsible for providing the reports.
Another example is when our audited reports come out, the auditors prepare that, the board accepts it if that's what you want to do. If there was a loan document, then it would be signed by the treasurer, for example, after the board had approved. It's all corporations need to have a president, secretary, and treasurer.
Yes, this is something that's mandated by law.
Yeah. Most of the work is done by Jan and Sharon, whatever. It's just one of us putting our name on it.
That's correct. It doesn't alleviate you of the responsibility to be looking into the organization's finances or the laws. Of course, we're all responsible for that anyway.
Yeah, I would be willing to.
Okay, you're going to learn the hard way. That's good. Okay. So we have a nomination as for president would be myself, Gerald for secretary, and John as treasurer. All those in favor?
Aye.
Okay, passes unanimously. Okay. Somehow I have that down in a different spot. Okay. Now we go to the May financials.
Okay, so did everybody receive the report that I sent you? Both reports that we sent you, yes?
What you receive is fairly comprehensive, and it does, I think, over time, as you start looking at the financials that you receive, it's going to take you a little while to get your wheels going on that because it's a multi-page spreadsheet that we get. And I kind of like looking at it, and that's me.
One thing that I would encourage all of you to consider, the Monday before the board meeting, we have a finance meeting. And it's a great opportunity for you to come in and we'll go through a lot of detail. So if you have questions, Don never has a time where he doesn't have questions.
Cheryl loves me for that.
And that's always at noon?
It's at noon.
Noon on Monday before.
And that gives you an opportunity to ask anything that you aren't certain about or would like more information on. Because in a forum like this, it's hard to go through all of the detail. And we can provide as much or as little as you like.
Okay, so I guess what I wanted to say is, I did send you an extensive spreadsheet with lots of tabs, and at the meeting on Mondays, we usually go through the detail tab, and it gives you by department level of expenses, and I put a lot of notes, and I've tried to do extra notes for you, knowing that it's going to be fresh information to you. So I put kind of my idea of why some of these variances are what they are. So if you have any questions, please don't hesitate to call me, and then we keep it kind of high level here. All right, so the first slide, we're looking at our patient counts for the month of May. Oh, Jen, what did I do? I don't know, I pushed the button. Okay, never mind.
Now you're good.
All right, so here's the month of May, right here, this is the hospital. I don't include the births in this total right here because they're already included somewhere else, so that's a duplicate. But I thought it'd be kind of fun to start looking at the number of births that we're having here every month. We had 5 in May, I think an interesting thing is that year over year, we've had 17 more babies this year than we had last year. That's a lot of babies. Okay, so we had 356 patients in the hospital for the month. Our average this year is now 299. Last year at this time it was 330, so we're down quite a few patients mainly. We've seen a decrease in our emergency patients. We have seen a lot of decrease in emergency patients over the last couple of years because we've opened a walk-in clinic, and so many more people are going to walk-in clinic, which is where they should be going. We've also seen quite a decline in surgical patients, both inpatients and outpatients, because we didn't have an orthopedic surgeon for part of the year. And Dr. Chang is really picking things up, and you look at, we had 36 outpatient surgeries in May, which our average this year is 24 a month, last year was 31 a month. So we're definitely seeing an increase in those numbers, and that's good.
So, the clarification though, this does not include the long-term care.
No, but there'll be separate slides for that.
Because we got separate, those were all separate statements.
Yep,
That's
they're
right.
separate, they are not included in this financial statement.
So that you understand, one of the things, when we separated out the companies, we tracked that because that was, the auditors at that time felt that was in the best interest for reporting and getting paid from Medicare and Medicaid that way. Now, new auditors and accounting firm, which is Whitley, a national firm, they now wind all of that information up together. So our audited financial statements.
It's shown on separate lines, but it's yeah.
It's on separate lines, but it's all consolidated.
Right. And I gave you guys that report, so
But for our purposes, knowing what Lakeview Gardens is doing is important.
it is,
It's important.
it is.
That's why we keep it separate.
Okay. So anyway, these are our ancillary services. Lab had a huge month with 3,000 labs, but our average is 2,850, so this is a big increase, big month. Year over year, labs had 8.7 increase, radiology's up 9.5, rehab's up 9.9. All of these numbers are really big. These departments have really made the difference in helping us overcome not having an orthopedic surgeon and what that impact was on our financial statements. Home health and hospice is really varies. If you look back at it for a few years, it's up and down. It's very hard to predict. This year it's down just a little bit. And then we have, this is our health clinic in Lakeview. We saw 1,118 people. That's an
That's
increase.
the walk-in clinic?
No, it's the whole, it's walk-in and it's appointments and it's the whole clinics down there.
Oh,
Especially
It includes the
surgical.
walk-in.
Yeah, it does include walk-in. This is the Alturas Health Clinic that just became part of the hospital within the year. And then the Wellness Clinic also, when you look at the year-over-year increase for them, it's 20%. So we've added a lot of resources in the Wellness Center and we're seeing a lot more people. We also like to keep a look on behavioral health, yeah, sorry. Of which there are the three components. There's a wellness center, there's substance abuse, and there's the children's wellness. And then the last thing we look at is our average daily census for acute patients and swing bed patients. We did have 10 swing bed patients for the month. Swing bed is a significant impact on our revenue, so it's an important thing that we want.
Do you remember how we talked about what a swing bed is versus an acute patient? So as part of being critical access hospital, there are three components principally that we have to abide by. Number one, we have to be located more than 35 miles from the next nearest hospital. Number two, we can't have more than 25 beds. And number three, we can't have patients stay in the hospital on average with a length of stay longer than 4 days. You can still have some people that are in for a day and others that are in for 5 days, but on average, it can't exceed 4 patient days. There are then some patients, Medicare patients, that come into the hospital as a swing bed, and it's sort of something like a skilled nursing care service. And they can stay in the hospital for up to 99 days per
That
stay.
doesn't count in your average.
It counts differently. And that's why we separate out swing beds from acute care. And that's what those criteria are.
Okay. Okay, this chart, we're looking at our monthly gross patient charges, so that's our charges before contractual adjustments of any kind, and only for patient charges, no other kind of revenue. This month, we had $3.6 million, it's here on the chart. It was a good month. Our patient counts were high and our revenue was very, very good. So we've got all this information in case you want to look, 12% growth from the prior year and averages.
I would point out that the gross monthly charges are not what we really get because of the Medicare, Medicaid adjustments and other adjustments, charity care, et cetera. About 22% of that we will not receive.
Right.
So even though the gross is 3.6, it's going to be 22% less than that, about 80% of that.
Okay, collections on accounts receivable. So the last 3 months, March, April, and May have been very good months for this year. These are numbers close to where they should be. We were not collecting the way we should be back here. So this month was $2.5 million, 2.564. Our growth year over year is 5.6 million. I mean 5.6%.
Why was there such a drastic difference with collections right there?
Because we struggled with our revenue cycle manager in our business office, and we ended up.
What is a revenue cycle officer?
Our revenue cycle director, Susan Poitier, is our new revenue cycle manager. She manages the entire revenue cycle, so that is the people in admitting, all the way through billing and collections to when we actually deposit the money in our bank. So she's got a team of 20 people who do all of those functions, collect information, verify insurance, get pre-authorization sometimes, send out the bills, work on why they didn't get paid, send them out again. What else am I missing?
We also had problems with billing software programs and
Yeah.
we ended up being late on some of them and hopefully we're getting squared away and I think it's reflecting in the increased collections that we've got.
In the past, we often called that position the business office manager. But what we look at is from the moment the patient is in the hospital and they're generating charges, that revenue, we track it from that moment. Any of the billing, make sure that it's done correctly, that when the doctor sees, prepares their charting, how long does it take from when the patient is discharged to charting is done? How long does it, that entire cycle process? And when the patient starts getting charges to when we actually collect the money. That's the revenue cycle.
That includes working with financial aid, so all the patients who want to apply for financial aid, we do all of that. It includes sending accounts to collection and working with the collection companies. It includes a huge amount of dealing with software problems when the software doesn't work, as well as working with many regulatory agencies, the state of California, the state of Oregon, and all these people that we have to make sure all of our ducks are in a row before any of them will pay us.
So this new software that's coming up?
Yes.
Is that going to
Yes.
help?
Yes, and we have several different pieces of software now because we don't use the same one for, we have one that we use for our behavioral health, we have one that we use for our clinics, we have one that we use for our hospital. And so we have people that are experts in one and not the other, and it's very complicated.
The new program hopefully will put all that together into one,
It'll just be one.
so hopefully we'll get
Yes.
more efficient.
Oh my gosh, yes.
In a perfect world, you know, I was pointing out, we went back and looked, we had $3.6 million in billing this month, and we've got $2.5 million in collection. In a perfect year, you put out your bill, 3.6 million, and then the next month, you'd collect your 3.6 million. And of course, we're not in a perfect world, but we also have to look at that discount that all of those providers take off of that gross amount. So I think probably if it were perfect, $3.6 million billing, we would receive somewhere 2.8, 2.9 million.
Yeah.
So hopefully next month, when we look at the June collections, it'll be 2.9 million.
It will lie.
But the thing is, I mean, we have aged accounts receivable, you have people that can write off, you have adjustments to make, and it takes, unfortunately, more than 30 days to collect our receivables. So it's just part of the way our business runs.
So then we look at our days in accounts receivable, and this year is the red line. On all of these charts, the current year is the red line. Don made me make them all the same, so all of them are 16 is yellow, yeah, just so you catch on to that. It is helpful. Red is the current
I
year.
was colorblind.
Our days in AR was at a high of 101 in January. We are down now to 72. We have as our goal to be at about 60 days. One thing that we're not able to do, that when you look at benchmarks for other hospitals, they're going to say, yes, we're at 60 days or we're at 45 days or whatever it is. What most people in the industry are able to do now is to take out your payers who they're usually individuals who have signed a contract with you to pay off their portion of their bill. And they've agreed to pay $50 a month for 5 years or whatever it is that they can pay to get their bill paid off. And that's usually after insurance and after financial aid or whatever we can do to help them get it down. And then they agree to pay it. Now, usually people take that set of their accounts receivable out of this equation. We're not really able to do that right now, the way our software works, without a huge amount of manual labor, which I'm not sure is worth the time. So those account for that as well. We're talking about ways to do it because we would like to be able to, you know, when you all look at benchmarks and you're reading and you say, how come you can't do that well? We would like to be a little bit closer to comparable and have it be an apples to apples comparison and not something else. So, okay. The other thing is, this is just the hospital's AR. I don't really do separate accounting for the Credible software or the clinic software. Clinic collections are, generally speaking, a lot faster and easier than hospital, and that AR is only around a few $100,000 a month, so it's not anything compared to this $7 or $8 million.
Tell them what Credible is.
Credible is the software that we use for our wellness center, our behavioral health. And generally speaking, we get paid more by state allocations and GOBI for mental health than we do for patient collections. That's a very small, really, ultimately a small piece of that business. Okay, days cash on hand. This black line here is the 90-day mark. That is really where we need to be for our covenants with WAFED on our bond. And we have the bond covenant is an and. You have to do this and that. And so since we have failed on this one, we are making it on our debt coverage ratio. So we haven't really gotten in trouble. We still would really like to see this above 90 days. I would really pushing to see that. We were down, the low was 58, now we've brought it up to 68. It does not rise as quickly as days in AR. It goes down, unfortunately, but.
And the reason it goes down? Why is it down?
Why does it go? Because we have used up a lot of our cash reserves on growth, and our expenses are high. So this number is looking at 12 months of average expenses. We had very high expenses this year because even though we had a bond to pay for the building, we ended up buying equipment. We ended up paying out cash to prepare that space down there for the clinic to use it for several months while their space was being remodeled. We used it to buy furniture and equipment for all those new spaces that we needed. So a lot of new,
There were a lot of
outfitting.
one-time expense.
Yes. Yeah, a lot of IT infrastructure. So that's, I mean, we can probably talk a long time on that if you want to sometime. Okay, that's the high level view. Okay, so this is the profit and loss just for the month of May. This is the actual, the budget, and then we look at prior year, and then the two variances. The net revenue for the month was $2.7 million. That was $155,000 above what we budgeted, and it was $229,000 less than what we had last May.
I would point out the revenue deductions, 3.6 million in billing, 2.7 million in the net, which we hope to collect.
Right, which is what we should ultimately be collecting in those following few months.
She's smart.
45 days. Expenses, total operating expenses, division, total expenses, 3 million, which was 245,000 more than we budgeted to have. And then for the year, it was 368,000 more than last year at this time. Just for the month, we did have, this is a big month of expenses. This is a high number right there for us. Our gain or loss for the operating, so essentially this is our operating loss. It was 273,000. We budgeted 182,000, so 90,000 worse than what we planned. And then our net positive gain for the month after non-operating income, which is our tax money and donations mostly, we had a $7,000 net gain, $20,000 less than budget, $74,000 less than last year. The month is interesting, but I think the year-to-date statement is more important for us to focus on. Gross paid, or net operating revenue is now 28.4 million, which is only 22,000 less than we budgeted. And if you will look at the detailed P&L that I sent you, you're going to see that surgery and anesthesiology and central supply are hundreds of thousands of dollars under budget. And in spite of that, we are just $22,000 under budget for revenue this year. So that's a very positive number. We have $3.5 million more revenue than we did last year at this time. Our expenses are also quite a bit higher. Our total expenses were $30.6 million. The operating loss was $2.2 million, which was $237,000 worse than what we budgeted. $13,000 less than last year. Our net gain so far this year now is $397,000. We budgeted for $301,000, we're ahead by $95,000. We're ahead of last year by $40,000. Do you have any questions on that?
A lot of questions, but I'm
Yeah.
going to go out of the weeds. But a couple questions. What is central supply?
Supplies that we charge patients for. I mean, so
Why is that off so bad?
because, well, the biggest thing would be, because we're not doing orthopedic surgery. So we budgeted for, an orthopedic surgery includes implants, which have a very high, they have a very high cost and you charge a lot for it. So all of those things are, so anesthesiology, the supply items used in the OR and the OR itself are all way below budget. So, I mean, they're all
A hip and a knee, I mean, those replacement parts are really, really expensive.
really expensive. And they're way under budget, but they're not losing money. You have to be careful of that. They're,
So it's way off the budget.
yeah, they're way off
Way
budget.
off the budget. So the sale is not there,
But
and the
neither is
expense is
expense.
not there. But that's why you're so far off.
Yeah. Well, I mean, I'm surprised that we're not further off based on when you look at those details. Okay.
So we're
I'm
not
probably-
doing orthopedic now?
We're not. We're looking for another orthopedic surgeon and we have high hopes that we've got one coming.
My right knee is asking.
You what?
My right knee is asking.
Yeah, Yeah,
You
we're,
Marines, you all have bum knees.
That one works great now. The right one wouldn't work as good.
I have questions on the balance sheet.
okay. Balance sheet. Looking at prior month, not a lot of changes. Looking at prior year, get my notes. So what's happened on the balance sheet this year is, this receivable number went down because of adjustments made by the auditors at the end of the year, which has a lot to do with bad debt from Lakeview Gardens, okay? Or I wouldn't even say it's bad debt, but it's money that we sent over to Lakeview Gardens that we're not gonna get back, okay? And then net patient AR is up because our revenue is high. Investments is cash. These are all three are cash accounts. And there's movement, I mean, there's less cash, there's like 400,000 less cash right now than there was a year ago at this time, but it's just in different accounts. So that's the assets. Fixed assets has gone up quite a bit because we did the clinic building this past year. So we had the bond sitting there, and every time we borrowed money, we would debit the construction in progress and credit our long-term debt, essentially. So that's gone way up, and the fixed assets have gone up.
Well, one of the things that I don't understand